We're about to watch and react to episode 6 of The Pitt, but for this episode, I need to call a consult from the one and only Dr. Al-Hashemi, Sepideh Moafi. Are you ready to take on episode 6 of The Pit?
Let's do it.
Yeah?
Born ready, baby.
Okay, let's do it. And huge thanks to ZocDoc for sponsoring this video.
I'm in. Weigum.
I am notorious for pointing out chest compressions not being done or being done perhaps not perfectly.
Okay, how's Robbie doing?
So I'm a bit of a stickler for form.
Okay.
Only because what I've come to realize in my years of practicing medicine and making YouTube content, people learn from television on what they should do, what they shouldn't do, what they think is correct. So I would love to see the chest compressions be a little bit deeper. But otherwise, it looks great.
It's hard because
it's a real
when they teach, it's a real person, so you're having to keep your arms straight and sort of push your chest forward and kind of act with your shoulders. And so it's a very sort of artificial movement, but yeah, it's actually harder than it looks.
I think it's really smart in the way that they manipulate the camera angles. Because honestly, it doesn't let me give critique because it's like, oh, we're just seeing the shoulders bounce and that looks good already because most people are doing stuff like this.
Yes, you should text Noah though and let him know that he
No,
needs
he's
to brush
doing a
up
good
his
job.
game.
No, because then poor Louis over there is going to start really feeling it on his ribcage the next morning.
That's right.
Okay, holding compressions.
Good square line on the end-tidal CO2.
BFib. Charging 200.
Charged. Clear.
Stand by with epi.
So that's very concerning. We're starting to see blood enter the ET tube, signaling that there's some kind of bleeding process going on. And I believe this patient is one who's come in multiple times for alcoholism and already has fluid building up in his abdomen. They had to do a paracentesis. In those patients, they have scarring of their liver. That increases blood pressure in the portal venous system. And what happens there is the body tries to decrease this pressure by shunting blood in different directions. But the problem is the venous system is not meant to be a high pressure system. They're thin-walled and they don't respond well to pressure. So when that blood flow starts getting redirected to areas like the stomach, the esophagus, those blood vessels that are thin start becoming wider. They are more susceptible to rupturing. Any amount of slight friction, pressure, ET tube going in, all of that can risk bleeding. And in general, patients who are end-stage liver disease also have issues with platelets, clotting factors, because a lot of that happens from the liver. A lot of problems with bleeding in these patients. So very tough to see a situation like this where it's already terrible because we're in cardiac arrest, and now there's problem on problem on problem.
And this is a character that we, as an audience, have grown so attached to. Louis, this is, Yeah.
Section that too. Not in the esophagus, sorry.
Definitely not. I passed right through the cords. Good breath sounds, end-tidal CO2 confirmed.
His lungs are filling up with blood.
This never gets easy, by the way, watching this amount of blood. And
Are you squeamish of blood in general?
I didn't think I was squeamish, but yeah, my first day we did the clamshell procedure from episode 1. And so I felt like I was getting a bit lightheaded because the full body prosthetics, they look so real.
Yeah, exactly.
Every detail, every is accounted for. So I still, and watching the show, like during the clamshell, even though I was in the room for however many days that took, it was hard for me to watch.
Are you filming a scene like this straight through, or are there stops for angle swaps, camera changes, etc.?
No, we actually have less downtime than most film and television.
Okay.
Yeah, shows and films, because the light is already prefixed into so it's basically hospital lighting that we're using, and there's a switchboard where there's very little downtime between setups, but we do take a good amount of time to rehearse the trauma procedure. So we have a med tech advisor for every episode. Usually I call them and bother them for as long as they'll talk to me and let me pick their brain. So on the day of the procedure, we'll go through, they'll talk to each one of us individually, sort of give us the lay of the land, and then put it all together, run it at 25% speed, 50%, 75, and then bring it up to speed. And once, they feel it's ready, then we roll. And yeah, like I said, there's very little downtime between shots.
Yeah, this 25, 50, 75, 100 approach is very similar to the see one, do one, teach one that has been discussed on the show.
Yeah.
It allows you to get more and more comfortable
Yes.
without feeling like you're going to make a mistake, and it comes off perhaps less genuine.
Yes, absolutely. But I mean, once you get in that flow state, once you're in the pocket, it's thrilling. I mean, I'm glad there are no lives actually at stake here for us, but it really is, because it's the sort of codependence or interdependence of your colleagues, of your scene partners, and everything. We just rely on each other so heavily.
Hold compressions.
Asystole. Resume CPR, another amp of epi.
Needs more section.
Pulmonary hemorrhage from liver failure.
Is he going to make it?
See, it's hard to know if, at least for me watching, if this is a pulmonary hemorrhage or, as Noah mentioned in the scene, was this a situation where the ET tube was inserted incorrectly? Because of those fragile blood vessels that can occur from advanced liver failure in the esophagus. If you insert there and you injure one of those blood vessels, you can't tell, is this bleeding from the mouth coming from the esophagus or from the airways? There are obviously situations from this pressure buildup, the coagulopathy that happens as a result of liver failure, that could lead this to be alveolar bleeding. So like the smallest little pockets, air sacs, within the lungs that can cause bleeding, but very difficult to know. And in an ER setting, it almost doesn't matter because you're trying to do your best to bring this person back. But in a scenario like this, it feels very far gone.
Should we give PCC?
Too late for that. And he's not an ECMO candidate.
Nothing else we can do.
No, I think we're done.
Wait.
$12.07.
Why do I need to see a psychiatrist? Jada, why do I need to see a psychiatrist?
Oh, it's gonna be okay, Jackson. Dr. Jefferson says he can help.
Do you know how you got here?
The medics brought me. I don't really remember. I was in the library.
What were you doing there?
I was studying. I was trying to study, but then they wouldn't stop talking.
Who wouldn't stop talking?
They told me to pass the bar.
Who doesn't want you to pass the bar?
That's what they told me.
This is a situation where paranoia is entering the equation because there may have been no other people actually interrupting his studies. Schizophrenia is a possible diagnosis, especially in this age demographic, is when it can start. And the interesting part about schizophrenia is sometimes it's brought on by some acute stress state where we cannot even predict why it started at this moment, but something happens in someone's life, something very stressful, a critical illness, and then full-on schizophrenia begins, where before that, there were no signs of the schizophrenia. Very interesting.
I was fascinated by that in talking to our tech advisors, our medical advisors, that this is apparently very common for young males in their early 20s, in college, high-stress environments, and especially with marijuana, when they're smoking marijuana.
Everything okay, Roxy?
I can't get off the bedpan.
Well, that's what I'm here for. Your husband seems like a saint. How long have you been married?
Too long. Almost 20 years.
I always find it tough in scenarios like this where a patient is obviously in a lot of pain, is going through final stages of their life. It's hospice situation. So you want to approach this situation with reverence. You want to be serious. You want to be compassionate. At the same time, it's so important to also interject some happiness, some humor, some joy, but then it's very easy to cross that line.
Yeah.
And finding that line with each patient is, I think, the most valuable part of being a clinician.
I was just admiring Kristen's work because she's so beautiful and alive and real and just present in everything that she does. I think she's just such a beautiful, brilliant actor. But it's a cast of people like her who are just making really smart choices with the script that we have, which is so well written and loaded and really kind of like a treasure chest or a minefield, and you just continue to mine as an actor and you get more and more. And these moments of levity that you're talking about, I was thinking as we were watching it, the way that the camera is panning down to the bed and then up to them, it makes you feel like you're inside of the room with them, like you're experiencing it, and it creates this other dimension of humanity and authenticity for the show that makes you then, in these quiet moments, relate even deeper to these characters, whether it's the patient or the nurse.
This feels like I'm shadowing a nurse for the day to see what they do. There is no difference between this and what I experienced in the hospital. I think it's
I believe this one's directed, if I'm not mistaken, by Noah.
Oh, really? Okay.
Yeah. So it's always interesting. You'll see this season, Sean directs in episode 2, episode 9. This kind of this level of detail is so important for them because they are actors. They come at this from the inside out. Whereas a director that comes from maybe a photography background or a filmmaking background, it's more of an outside in approach. And both are right. Both are equally as effective. But I think as an actor, it's really satisfying working with somebody who understands it from the inside out and cares, pays attention to these details because they know that the audience will feel them.
Sure.
Let's discuss our incarcerated patient, Gus. Prison infirmaries tend to be short-staffed, so we need to be thorough. What's in the differential diagnosis for malnutrition?
Inadequate intake, methamphetamine use, severe alcoholism, ADHD medication.
What else?
Cancer of the oropharynx, esophageal strictures, prior strokes, malabsorption, inflammatory bowel disease, none of which were in his medical record.
I don't think it was noted, also past bariatric surgeries. So patients who have a bariatric surgery sometimes have a malabsorption syndrome where they don't get their nutrients as well. And this type of questioning happens very often. In the House MD days, they would be in front of a whiteboard. And that's so not realistic, with the exception of if you're doing we have these rounds called M&M rounds, morbidity, mortality rounds, where if someone dies or someone's very sick, at the end of the month, we collect these cases, we present them, and then write on a board. But when we're actually taking care of a patient, this is the exact way that they're done.
And we sneak in little, drink or food breaks to kind of, make sure the audience knows that we're not, that doctors eat too.
Let's start with a nutrition history once he's back from CT.
What is the story with your incarcerated patient?
Gus Varney, 3 rib fractures with normal O2 sats currently, waiting on CT results.
Okay, if he's stable at the 2-hour mark, I'd say he's good to go. Let's get the ball rolling on discharge.
Let's wait on the CT results.
We can move him out of trauma 1 at least.
Yes, we can. What's open?
13 and 14 will be discharged soon. 15 once we can move Louis to the viewing room and get it cleaned up.
Our paracentesis patient, Mr. Cloverfield?
Defib arrest. We'll do a debrief when we know how many patients we're getting from Westbridge.
So Gus goes to 13, 14, or 15.
I kind of want to keep him in plain sight. What about BH2?
Sold. Why not give him some privacy? Everyone can see him in BH2 like he's a monkey at the zoo.
Because he came in with an orange jumpsuit, we need to think about patient and staff safety.
Safety first, BH2 beats a prison cell.
Not by much.
You guys have a lot of tension going on there.
There is some tension.
There is push and pull.
I think friction can be generative, though. And I think that's what's interesting about the dynamic that Dr. al-Hashemi has introduced into the Pit. It's a different tune, it's a different melody, it's clearly a well-established culture, ensemble, ecosystem, and she sort of steps in and brings something kind of radically different and tries to harmonize as best she can, but there are some clashes sometimes between her and Robbie. And I think just as an audience member at this point in episode 6, if they can find a way to work together, I think they could be an unstoppable team. And I think what they represent is, more of this old school, hands-on, intuitive approach, Dr. Robbie, and Baran al-Hashemi, who represents this newer, more progressive, the modernization of medicine, what could be.
I'm sorry, man. We didn't have time to find you.
What happened?
He was apneic, impulseless.
We started CPR and intubated him. He had a massive pulmonary hemorrhage, Robbie called it.
Could have been as simple as, because he has this liver failure and he has the high capacity for bleeding or high risk for bleeding, and doing chest compressions, you break a rib, punctures the lung. That alone could have caused this.
You ever clean a dead body? Probably never seen one either. No one tells you what it looks, feels, or smells like, but you get used to it over time.
This is mostly for dignity purposes, to have the patient be available for someone to view before sending him to the morgue. But you're not doing like an embalming process here.
You pull off the gown, wipe him down with towels, and we'll roll him on his side. Clean his back, stuff the sheet under him.
Pads for mucus and other bodily fluids that might come out after the fact.
Usually, leave the ET tube in for the coroner, but Louis a chronic alcoholic with end-stage liver disease, not a coroner's case.
Yeah, so usually we would call the coroner as residents, present the case, and they would decide whether or not this was necessary to be a coroner's case or not. The most difficult part is this doesn't happen as much in the ER, but when someone's admitted to the hospital and someone dies, you go in as the resident and you have to formally diagnose the patient as dead, deceased. You're looking for certain reflexes, pupillary, corneal, listening for extended periods of time for lung and breath sounds, and the whole family's there. So you're trying to be respectful. You're talking to them about the process of what will happen in the coming days. And there's times where you're talking, but you just know none of it's landing.
Yeah.
So you just have to be there, ask a lot of times if they have questions, and suspend talking and listen more, even though your job is to talk. Because in that moment, the information's not landing, it's not valuable. So.
And it's a way, I mean, this is, reminds me of, you know, how we approach our work as actors. Sometimes you have the language on the page, or what you're saying, you're taking this family through this process, but you're really communicating something else. You're communicating love and care and presence with this language. And so often as actors, we have the language in the script that we're communicating so much more with. So
What's up with Evel Knievel?
Brandon Lee, 52, fell off a motorcycle pyramid at 25 miles per hour.
Motorcycle pyramid, you recruiting? Got a fellow rider in your midst.
No kidding.
How high up were you?
On top of a 321, but the bottom guys are sitting down, driving the choppers. I'm fine. I don't need all this.
Were you wearing a helmet?
Of course.
Oh, what do you know? They're still in style.
Good vitals, tender right wrist, and big left knee lack.
Hey, Joy, Perla, trauma 2. Who else can I have?
Santos and Whitaker in with Louis.
Yeah, give me Whitaker. He could use a distraction. And Santos has been ducking traumas all day.
She's behind you in her chart.
Who isn't?
If I'm being honest, I'm currently very behind on my charting. I'm getting messages right now about it. I can feel my phone getting the vibration alerts. But interestingly, my hospital is beta testing an AI system to try and figure out how to make this more clean, quicker, more effective, with the concern from every doctor that, oh, will we now be seeing double the amount of patients because we have this AI system?
That's a slippery slope. But it feels like, yeah, most people that I've talked to, most doctors that I've talked to welcome this change, because especially people who are of a sort of like in, maybe I'm assuming we're kind of in a similar age bracket and older, because you've trained with hands-on, you know, medicine, and you know how to use this as a tool, not as a replacement.
My biggest thing when I was in residency training, I would get in trouble because I refused to do, the rule was do your note in the room with the patient. And I just refused to type when I wanted to interact with a person.
Yes.
I couldn't be that keyboard warrior. And that meant after hours, I would be sitting and doing notes and trying to catch up. But now with these AI tools, perhaps we can just have something on the desk that is no longer creating a barrier to communication and kind of stays out of the way.
Well, and it strengthens the bond between physician and patient, right? Because there's that psychological, emotional attunement, and they feel, and you earn their trust that way. And people who are coming, whether it's to checkup or for some sort of illness, there is this power dynamic of, you guys we're coming to you for your expertise and you have the answers. And so when you do see your provider locked in and sort of at the same place with you emotionally, mentally, it makes a world of difference. And then you feel like, okay, anything you say, I'm happy to do. I'm happy, rather than having to fight to earn the trust.
I don't even like getting to the point where a patient feels that they need to make the decision to do what I'm telling them to do. Mm-hmm. I want it to be an educational experience where I'm explaining what the options are, perhaps giving recommendations, but ultimately it should be their choice to want to or not want to do something.
Good lung sliding bilaterally.
Pupils equal and reactive.
What do you ride?
The Bullet.
Oh, Royal Enfield, ankle breaker, thumper.
BP 138 over 80, pulse 94, pulse ox 98.
So far, everything's very reassuring, and he's all mentally there, being able to memorize or call back the name of his motorcycle. So reassuring.
Does anyone have any trauma scissors? I'll check the knee.
Not yet.
Why not?
Dr. Santos?
Primary survey means rule out the life threats. Don't get distracted by lacerations or fractures. No free fluid in the belly.
Airway, breathing, circulation are fine.
Okay, that's ABC. That just leaves 2 letters. Tell
D-E.
Disability. Wiggle your toes, sir.
Any pain in your arms or legs?
Not really.
Does it hurt when I push here?
No.
Okay, no midline tenderness, nexus negative.
No obvious brain injury or spinal cord injury.
That just leaves E, Joy.
Can I buy another vowel?
Dr. Whitaker.
Exposure.
AKA strip and flip. Cut off his clothes and we'll log roll him.
A lot of times in the hospital, that is one of the most anger moments from the patient because they're like, this is my favorite shirt. Don't cut it.
Oh, really?
Yeah. But they've experienced a serious trauma. You don't want to miss something because there have been instances where someone comes in, adrenaline rush because they got into a fight, they got shot as a bystander, and they don't realize they have a bullet hole in their leg that went through their tissue. And had we not exposed their full body, we would have never seen it.
Oh my gosh.
Very important to check the entire body.
Do you ride a motorcycle?
No. I've crashed a motorcycle, interestingly enough, when I was really young. And I haven't rode since. No. But I do race cars.
And you wouldn't? So. Oh, you do race cars, but that's different, right?
I mean, you still crash. I guess it's just safer.
Sure.
Helmeted motorcycle acrobat, 8-foot falls, standing on top of 5 riders. Primary survey normal, EFAS negative.
So in a scenario like this, where the exam seems fine, it's tempting to not do imaging. However, one of the criteria that we use to decide whether or not someone should get imaging stems from also the mechanism of injury. And an 8-foot fall at speed is a pretty serious mechanism of injury that would usually warrant imaging.
Another motorcycle accident. Hello, sir. I'm Dr. Garcia from surgery.
Hello.
Okay, we will roll him in 3, 2, 1.
They closed the drape! I'm always talking about the drapes not being closed, but I assume it's for filming purposes, right?
Yeah.
Okay.
Most of the time.
Okay.
Yeah.
Because a big part of what I do and what I train residents is they'll walk into the exam room, they'll do everything perfectly correct, like before, let's say, a pap smear. And they'll introduce to the patient what they're about to do. They're very calm, very kind, and they're about to start the procedure. And I'm like, hold on a second, if someone opens this door right now, the patient's fully exposed. You have to close the secondary drapes. I'm always yelling that.
Do they ever tell you, well, they don't on the pit and everything in the pit?
No, they don't do that yet. Back to the show in just a second, but first I want to tell you about my sponsor, ZocDoc, a free website where you can easily search and compare high quality in-network doctors so you can find the right one for you. Dr. Robbie seems like a great doctor to me, and he delivers exactly the quality of care I'd expect to find on ZocDoc, who can help you book in-network appointments with more than 150,000 providers in all 50 states. Look, I get it. Finding a doctor is not just hard for patients, but for me too. That's right, just because I'm a physician doesn't mean I get how insurance and all this stuff works. My dad and I have actually struggled with this together. He's a family medicine doctor too, and ran into a health problem of his own and needed to find a new doctor. We tried to find someone, but we ran into all those same roadblocks you do. Confusing websites, endless voicemails. So we tried ZocDoc and found the right person. They specialize in exactly what
what my dad needed, were close to his home, and actually had openings for new patients. My favorite part, you can see the doctor's actual appointment openings, choose a time that works for you, and click to instantly book a visit. So stop putting off those doctor's appointments and go to ZocDoc.com/Dr. Mike, also linked in the description, to find and instantly book a top-rated doctor today. All right, let's get back to the pit.
Gus here's wondering if he's clear to eat.
As long as it's a liquid diet. We have the results of your CT scan.
Your jaw should heal without surgery, which is good news, but it will be a few weeks.
Before I can eat?
Solid foods, yes.
We have a calorie-rich supplement drink called Ensure. Comes in chocolate, vanilla, or strawberry.
Chocolate, please.
Good choice.
How many can I have?
2 a day is recommended.
I'll get it for you.
You have an appetite. It's good.
Mr. Varney, your blood tests indicate low levels of protein and vitamins.
This actor, John Lee Ames, I think is his name, he was so detail-oriented and so specific about his pain. I mean, he broke your heart. I couldn't watch him on my coverage because I'm supposed to be tough. And I would just crumble. I'd start crying. I love that they've sort of folded this case into the conversation that, you know, because it really makes us reflect on who gets care, who deserves care, who's afforded care, what kind of care do they deserve. Because he looks, initially, they made him look like kind of a serial killer or something, you know? He looks the part, but there's a softness, this childlike quality about him that even when she says chocolate, he says chocolate, his eyes light up. It just broke your heart. So again, going back to what the show does beautifully is it reveals the humanity in all of us.
Yeah.
At the surface, we might judge somebody like that, but then you see he's just a kid who wants to eat, who wants to be taken care of.
Which there should be no barriers for anyone to get care. Criminal, not criminal person, who wants care, who can't afford care. Like, the idea is we should be giving care, especially in an ER setting, to everyone at the highest level.
CT's ready for Brandon.
As soon as we take a look at this knee.
Ooh.
Whoa.
Through the deep fascia.
How's it look?
Definitely gonna need stitches.
How many?
A lot.
It could be an open joint.
We'll do a saline load after CT.
Lever sign negative, ACL intact.
Okay, ready to roll.
I'm not gonna lie. It's really tough to know if the ACL is intact from doing that sign test when the knee is in that shape, when there's that much damage. During global swelling like that, it's very difficult to have clear tests, with the exception if there's a full tear and there's just full laxity when you're doing certain special tests. But in general, it's tough to point that out.
We need to admit our incarcerated patient, Gus.
What did the CT show?
Moderate pulmonary contusion, 3 rib fractures, no intra-abdominal bleeding, and oblique fracture in the body of the mandible anterior to the angle.
All favorable for healing. What's the treatment plan?
A pain medication, antibiotics, liquid diet, pulse ox a few times a day, and then also dressing changes for the laceration.
Which he can get at his correctional facility.
Or he stays here for a few days and we get him on the right track to healing.
Why don't you two go check on your patients?
Sure thing.
What am I missing?
That's a great question. I was expecting conflict, but he's admitting that he might be missing something. That's very disarming.
Do you think that's enough information for him to have to admit the patient, or?
In a situation where in the pit, they're already overloaded, beds are premium, you have to be aware that you need space.
Yes.
So you try and decrease the need for people to spend time at the hospital. In addition to thinking about the fact that every time you bring a patient into the hospital, you're risking them getting a hospital-associated infection. And in a hospital, traditionally, you're not resting well. The lights are always on, people moving around. Maybe correctional facility isn't comparable to home, but if you've spent years there and you're comfortable there, maybe you're resting there as well. But if he's not aware of something, some risk, some healing factor, perhaps this will change his guidance.
He's not getting enough to eat at his correctional facility. The portions are tiny, too many carbs, not enough fruits or vegetables. He's lucky he hasn't developed a chronic illness.
We don't have any inpatient beds. He would board down here for 3 days. We're still getting runs from Westbridge, and we cannot tie up behavioral for that long.
Also, based on his presentation, it would be very unique to understand why he's so advanced in his malnutrition as a single individual. Like, are they not feeding him specifically? Are inmates stealing his food? Some further questioning would be helpful here, because if that's the case, you can have social work actually begin the process of investigating the correctional facility and asking them questions.
Why don't I call the prison doctor and find out what they're working with over there?
Thank you.
My pleasure.
But see, in a scenario like this, it would be great to pawn this off to a med student or perhaps a social worker, not the director of the ED, so.
What do you say, kid? Ready to go home?
How's your pain, Mrs. Hamler?
It's the same.
We're gonna write you a script for Keppra. You'll take that to prevent seizures once a day starting tomorrow.
Between your broken leg and the bruises from your seizure, the pain will probably get a little worse.
Yeah, the most important thing is to let others help you. You'll need assistance showering and getting to the bathroom.
Yeah, no problem. I won't leave her side.
In a scenario like this, giving the plan is smart, but then asking the patient, does she have any concerns about going home? Because it seems like
there's
some
tense
kind of
dynamic,
hesitation
yeah.
there.
All right, fill me in. This is hologram. She was seen in triage. CBC and CMP came back normal. IT was supposed to bring the VRI down, but they're slammed. I know a bit of sign language. Harlow, this is Dr. Santos.
Hi, Harlow. How are you feeling?
She has a headache.
Okay, what else? What is she saying?
I think she had a stomach ache and she might have passed out.
This is getting into not great territory, because when you're trying to understand someone who speaks in sign language or communicates in sign language, or perhaps even just a different language, there's this temptation to take a shortcut of have someone who kind of knows the language to interpret. But there is a fine line between presenting accurate information and dangerously inaccurate information. So in a scenario where someone's not sure, it's better to communicate by writing in a scenario like this. It's actually why a lot of channels on YouTube will have their content dubbed in a different language. We have not yet done that in many languages. We've done professional transcriptions in Spanish, but not dubbing. Why? Because if someone is to dub my voice in a different language and slightly change the inference of what I'm saying, that can lead someone to making a bad healthcare choice for themselves or their family members in a different country. And it's very expensive to have a medical professional actually do that dubbing. So we have held off on that. But interesting to show how nuance really matters in healthcare communication.
Absolutely.
Yeah.
I'm not 100% sure.
Okay. We're just gonna need to wait for an interpreter because I need to ask a million questions and I can't do it this way. So just call me when IT comes down.
Talk to the patient, though.
Yeah.
Ortho assessment. Palpate all long bones, starting with the clavicle.
Got it.
I'll take the lower extremities.
Distal radius tender, no deformities, needs an x-ray.
No bony tenderness down here, no laxity of the knee.
Any concern about that knee leg?
It's an open joint. He'll need a washout in the OR.
We could try a fluorescein injection. Okay, we'll need a Woods lamp.
1% Lido with epi, sterile saline, sterile basin, sterile fluorostrip, 18 and 27 gauge needles, 5 and 60 cc syringes.
Interesting what they're doing. I guess they're trying to figure out if the potential opening has gone into the joint itself, because the skin and the superficial tissues there, the fascia, they can experience some infection, some bacteria, but if it starts entering the joint, that requires IV antibiotic treatment. So what they do typically is insert this dye that actually has been used in a previous episode to check for a corneal abrasion, similar premise just with saline, to see if it actually starts entering the knee joint. If it does, high risk for infection, so you want to be prepared for that.
Lights out, Woods lamp on.
You might want to use some of that on Halloween.
That is 250 cc's of sterile saline with one small touch of a sterile fluorostrip. We are going to inject this fluid into your knee, Brandon, and if there's anything glowing in your wound, we know we have a leak.
This could also be done to check for fistulas. If there's an abnormal connection somewhere in the body, you can inject into one part of the body and see if it transports there because of this new path that's created. And sometimes fistulas and these abnormal connections form just from friction within organs. So this is pretty wild, but you can actually develop your colon rubbing against your bladder to the point where you can create a fistula where feces end up in the bladder and you end up urinating feces, fecal material. Yeah. So imagine how scary that is to a patient when they start experiencing that and they present that way and they go, what is going on? Recurrent UTIs, foul smell, etc. That's why you need to always think about potential fistulas as part of your diagnosis.
You'd have to surgically operate.
Correct.
Right? Like you'd have to.
Yeah.
That looks good. Laceration did not enter into the joint space.
Surgery not needed.
Excellent. I can get back to the parade.
No, we'll still need to stitch you up and splint your wrist.
Taking a gram of Ansef.
Wait, he has a penicillin allergy.
No, Penfast was negative. We're okay.
My mom said I got a rash with amoxicillin when I was 2.
90+% grow out of their penicillin allergies from childhood. So a lot of people come in saying they have a penicillin allergy, and sometimes we do some testing to rule out if they still do. Because if they don't, it's better to use medication like penicillin, which has lower rate of side effects and is more targeted to the type of bacteria that we expect to find, therefore creating less bacterial resistance to antibiotics.
Yeah, probably not a true allergy. Go ahead and give it, Kim.
But have epi and Benadryl standing by, right?
Yes, to be on the safe side.
Well, it's the ER. I'm hoping that there is epinephrine and Benadryl.
Most people who think they have a penicillin allergy actually don't.
Always listen to the nurses. They run the ER. We just try and stay out of their way.
Facts. And in general, when people tell me they have a drug allergy, many times it's something like, oh, my stomach gets upset when I take this medicine. It's not exactly an allergy. And it's important to differentiate between the two because, look, having an upset stomach but decreasing the risk of a complication might be worth it versus someone has anaphylactic shock as a result of a medication. Way different propositions. So.
Hey, I just got word that the at-home morphine pump is going to be delayed. Hospital pharmacy has to mix it and then deliver it later today.
Well, should we keep her here until it's ready?
No, you can give her a 200 milligram tablet of MS Contin.
200 milligrams?
Biggest pill they make. Releases over 12 hours for patients with opiate tolerance.
Got it.
I'm surprised they're not doing fentanyl patches for her because that is a much more potent medication, but it's a patch, so it doesn't have to be taken by mouth, and you can get really high doses, which is why fentanyl could be so dangerous. But for someone who's, as he said, opioid tolerant, meaning they've taken huge doses, their body has become accustomed to those doses.
You gave us a clozapine alias about an hour ago. Your resident reported no surgical history, but the chart says they've had an appendectomy. We're not admitting the patient without a surgery consult.
Who called it in?
Dr. Trinity Santos.
Dr. Santos, you had an ileus patient. You neglected to mention a history of appendectomy.
There was no history of appendectomy. It was in your note. I may have forgotten to proof check it. I was using the app that Dr. al-Hashemi suggested to catch up on my charting.
Wonderful. Dr. al-Hashemi.
Yes.
Dr. Santos was just using your AI tool.
Oh, that can't be blamed on you. You have to proofread the note.
I said it!
It hallucinated a history of appendicitis.
As I mentioned to Dr. Santos, generative AI is not perfect. We still need to proofread every chart it creates.
The patient also has a history of headache, followed by Dr. Park from urology.
That should probably be neurology.
Unless urologists are now treating migraines.
Another example that should have been caught by proofreading. AI's 2% error rate is still better than dictation.
Yeah, I don't really give a shit whether or not you want to use robots down here. I need accurate information in the medical record.
Understood.
You know what I will say? We're having all these wars about this 2% accuracy. When I was on wards, you should have seen the handwriting of the specialist.
Yeah.
Completely illegible, completely. In fact, there were some, it wasn't even worth looking at the note. You would just know that they were there because their note was semi-present, and you have to page them every time. And you know what's weird? They were so sweet, and they would explain everything that happened. But why do you want the call? Since you're already writing it, make it legible.
Yes.
If they knew how we practiced medicine 20 years ago when there were no computers involved, this is a miracle compared to that.
And I mean, a friend of mine who's a doctor, specializes in end-of-life care, he says that, I mean, he's the most hyper-vigilant, obsessive perfectionist, and he's terrified of making a mistake. Because you're human, you know, you deserve to have a bad day. You deserve to be sleep deprived. The fact that that could affect someone's care or someone's diagnosis, so he is team AI because it can reduce human blind spot at the end of the day, but needs strict supervision.
Right.
I just got off the phone with the physician assistant at the prison. They've got a 16-hour-a-day infirmary with NP and PA coverage, giving everything that we need, and they've got an RN for overnights.
Even so, he's here because they're ignoring his basic needs.
He's here because somebody kicked the shit out of him.
I think you're missing the point. We have more to offer.
Robbie, got 4 more coming our way.
Okay, got it. What you're trying to do is very noble. We don't have the resources to spare.
Okay, then why admit the unhoused man, Digby? Why not send him back to the street with antibiotics and a roll of gauze?
Because Digby lives on the street, and your incarcerated patient has a mid-level provider and a nurse looking after him.
We both know the quality of care is not the same.
Sorry, you waiting for me?
No, Dr. al-Hashemi for the patient in 7.
A few days here could make a world of difference for Gus's health.
We are a safety net, but nets have holes. We are not admitting them because this is not about social justice.
Everything I've done in my career is an effort to improve the system. Just because you know it's broken doesn't mean you stop trying.
I think in a scenario like that, fixing the system could mean a lot of different things. Maybe it's not about admitting this patient to fix the system, but using that as an opportunity to create a line of communication dialogue with the prison system to find out why these holes in the safety net exist. Because in an ER setting, I would have to agree with Noah here in that in an ER, you're trying to stabilize a patient and either make the choice that they need to be admitted for medical reasons or they need to go somewhere, we call it disposition, where they'll be looked after. And if it's not a high complexity of illness, we can send them to a different facility to get care. But now if we feel like that facility is not doing a great job, we can start an investigation. We could start a line of dialogue. If you make the decision to universally bring people in, you'll get to the point where you can't deliver care to almost anyone.
Just from a story perspective and what this moment represents, these two characters is they're both coming in with their experiences, their biases. We'll learn a little bit later why Dr. al-Hashemi might favor the incarcerated patient in this instance. But I think she's had experience where these kinds of things are sort of pushed under the rug, and that's more the norm than anything else. And it also just shows their position and their philosophies as doctors, that he's somebody, the hardship that she's experienced that we'll learn more about has made her lean in more and become more empathetic and want to sort of refine and find creative solutions. And for him, it's made him in ways more callous and more detached. And so I think what this moment represents more is that the paradox or how they are coming at this from in a diametrically opposed way. They're just polar opposites.
I think it shows how, while healthcare is a science, it's also an art, and two good doctors can have reasonably different plans for a patient.
Based on their experiences,
exactly.
Yes.
Robbie, pulse ox just dropped.
What happened? I don't know. I stepped out for a minute.
It's down to 85%.
You having some trouble breathing?
A little.
Start him on 2 liters oxygen nasal cannula, titrate to 5, keep the pulse ox at 92 or higher. And
Does he have a pneumothorax?
He's gonna have to stay.
For how long?
Not sure.
Sorry, boss. I only stepped out for a second.
Let me know if anything changes. You were in the room when his pulse ox dropped?
I was.
What were you doing?
Dee still can't get a hold of ortho.
Leave him to me.
What did she put tape on it so it didn't catch a signal?
Can I assume that you've already called upstairs to get Gus Varney in bed? Do you want to tell me what you did?
I don't know what you're talking about.
His pulse ox was steady. We were about to discharge him. Did Dr. al-Hashemi put you up to that?
Al-Hashemi? No.
You know he's going to go back to prison after they discharge him upstairs. I thought you didn't go the extra distance for your patients anymore.
This is This is a little bit disingenuous.
Okay.
Saying that she's going the extra distance faking something for him is not necessarily going the extra distance. Now he might be exposed to extra testing that he doesn't need. Can also create side effects of that and more problems for him. Also, as an ER doc, you can call upstairs for an admission from us in the internal medicine or family medicine ward. We'll come down, examine the patient. If we don't feel like it's a good admission, it might get rejected. Yeah, so you're creating some interpersonal conflict as well.
Is this illegal, what she did?
I mean, no one will know. That's the real answer. In reality, all she needed to do was say, hey, his blood pressure was low, his pulse ox was low. She didn't even need to create that scene. And something to point out there is the pulse ox is such an imperfect device to capture someone's pulse. So if they have their nails painted, if their fingers are cold, it doesn't catch a good signal. So often someone's pulse ox drops and we readjust it and it's fine. The fact that his pulse ox dropped for 30 seconds and we readjusted and it was good, and that's the reason why he's staying, is also a little bit overblown perhaps.
Okay.
Found this with his stuff. Who knew he was married?
That's Rhonda, Louis' wife. High school sweetheart. He never really wanted kids. But Rhonda wore him down, and when she finally got pregnant, he changed his tune, he got excited. And then about a month before the baby was due, Rhonda and the baby were killed in a car crash. Louis never really came back from that. May his memory be a blessing.
His memory be a blessing.
It's so important to have those moments to not lose humanity for not just the patients, but also for the providers. It's so easy to get cold to death and destruction and mayhem when you're seeing it all day long. But at the end of the day, there's always reasons for why things happen, and sometimes we're not aware of them and we're quick to judge. So moments of reflection like that are so powerful.
Yeah, and it's almost like a ritual, right? It's a practice that becomes part of the humanity in care.
Interesting that, again, in an episode that highlights the humanity of patients and providers, we're also on one hand talking about how important it is to talk about humans, but also AIs in this episode. There are so many topics covered in this one episode. It's really impressive.
It's what's so compelling about this show, because on the surface, it's about a hospital. It's about these healthcare workers, but it really, in essence, it's about everything and everyone, all of these societal issues that walk through the door. From immigration, we'll see in later episodes with ICE, and last season, gun violence, sex trafficking, grief, poverty, houseless community. I mean, there's so many different things explored. And to, for example, with the mass shooting last season, we see, unfortunately, in this country, too often these cases, we'll read about it, or it'll be in the news cycle for a day or even a week, but then it's gone. And what the Pitt has done, I think for the first time in history, beyond documentaries, really showed not just the cost on patients, but also on the healthcare workers, and how Robbie last season was housing this PTSD and grief from his mentor's passing. But now this season, they all have a shared collective traumatic experience that they're holding. And like I said before, this scar tissue that forms that just gets, harder and harder to get rid of.
Yeah, there's some kind of metaphor to be had where scar tissue in the human body, whether it's on the skin or inside the body, it helps you stay functional because that's what its goal is. But at the same time, it doesn't replace the tissue that was there one-to-one. And it does make you, from tensile skin strength, a little bit weaker. A little bit less effective. So it leaves its lasting mark on you. And unless you address it and know that it's there, it's easy to think that, oh, you're fine. But in reality, it's not quite fine. You're functional, but that chronic stress can wear you down.
And the practice of post-surgery, at least I know this from a dance injury that I had, you have to massage the point. You have to care for and take care of yourself consistently, or else that scar tissue forms, right? Yeah. And so I think all of these can be viewed as metaphors for, you know, our inner experience too, our emotional lives.
And I can't let you go without pointing out that, speaking of societal issues, you've been very vocal about what's going on in Iran. First with protests, now with the war. Any statement you want to leave with the audience about what's important to you? Correct me if I'm wrong, you were an Iranian refugee?
Yes.
Okay, yeah,
yes.
so this must mean even more to you then.
It does, and I mean, a big population of Iranians migrated before the revolution in '79, and even more, I believe, if I'm not mistaken, after the revolution. My family stayed and fought for democracy, essentially, for as long as they could, and were there during the Iran-Iraq War as well, until they were forced to flee, like most refugees, and lived in camps. For a while, I was born in a refugee camp, and so that experience and this medieval despotic regime has really forged my worldview and my existence, like many Iranians. And seeing this right now, not only this uprising that's been repressed brutally, as always. We've seen this throughout the past 47 years, where there's mass uprising met with violent repression. Yeah. And so we saw late December, early January, there was a wave of protests that were the biggest in Iran's modern history about, you know, economic decline and inflation. And so bazaar owners, shop owners closed their shops and stormed the streets. And then, as per usual, it's a similar pattern where the regime will cut out the internet. So there's an internet blackout still, a few months in, and just, you know, ruthless execution. There are over 7,500 confirmed dead from the regime from those protests, and another 15 or 17,000 bodies that haven't been accounted for. But if history has told us anything, it's the number is often, it's so much more. It's far higher than what we know. They don't want reform. They've tried reform. They want a regime change, and they want to have a voice in change. There needs to be a regime that accounts for the plurality that exists in Iran of ethnic backgrounds, political backgrounds, religious backgrounds. And so it's been a 47-year struggle. It's been a century-long struggle in Iran. It didn't start with this regime, but it's certainly worse than anyone could have ever imagined. And now with the war, obviously, things have intensified, and I don't know of an example in modern history where we've been able to bomb our way into democracy, you know, from an airstrikes campaign. Yeah. It's very complicated, but what's not complicated is the humanitarian cost, and that people in Iran need our attention. They need our voices, to know that the world has not turned their back, that they're not being killed and repressed in silence. I think they arrested something like 50,000 protesters in a few days. And all of these people, they don't get proper trials. They're kangaroo trials, and they're given sentences like, you've created acts upon that disservice God, right, or an enemy of God, or some bullshit, excuse me. And then they're publicly hanged. They're publicly executed.
Even some doctors are being held liable for giving care to the protesters.
That's right. That's right. That's right.
Being pulled out of their beds in the middle of the night. It's just incredible.
That's right. And this new precedent of healthcare workers being targeted, it's really horrific. And so, you know, as best we can, we have to amplify and use our voices. And there are international laws against this that are obviously ignored.
And you work with the IRC, right?
I do, yes. The IRC, International Rescue Committee, which is a refugee resettlement agency. They provide services in 40 different countries and all over the United States as well.
Do they accept donations?
Yes, yes.
Okay.
Well, yes, would
great
love
opportunity.
To. Absolutely.
And I'd love to donate $10,000 on your behalf for being such a great advocate for an important cause.
Much.
So yeah,
that means so much. Thank
well,
you.
I think it's a small part where we can play a role. There's people all around the world that are struggling in these terrible circumstances where you wish you could be there to help everyone, but perhaps a small token of just our attention it can start a...
And one last thing that I want to layer in here that you'll see starting the next episode with my character. It's not a spoiler, but she worked with Médecins Sans Frontières, Doctors Without Borders, as a humanitarian aid worker, as a doctor. And right now, when we're living through or we're witnessing unprecedented humanitarian crises, from global disaster, climate disaster, to war and displacement, to rising authoritarianism and, the shutting down of medical facilities, clinics around the world. I think having a character like this adds a certain gravity to the world of the Pit, and an important representation or visibility that so many of your brave colleagues go and fly across the world to help in these war-devastated places and leave forever affected and forever scarred and forever indebted to be the voice of the people, their colleagues abroad. Because medicine, as you know, it's a language, and once you're a doctor in one place, you're needed everywhere. And so it's the same medicine, different dialects, but I think the practice, as we were talking earlier about the edge effect of, diversity actually is generative and can help us all improve and help our healthcare workers, as we've heard from testimonies of people who are humanitarian aid workers who serve as doctors in different crisis zones, that it does only make us better to keep our eyes open and use our platforms and our areas of expertise, specialties, or anything we can do to help. Yeah.
Well, I thank you for using your platform in that way. And we're going to leave some sources in the description of this video to push people in that direction. So thank you. And if you'd like to see me interview Dr. Al-Hashemi's adversary, click here to check that out. And as always, stay happy and healthy.